Ladies and gentlemen, I represent the Laboratory of Clinical Immunology and Tumor, headed by Madam Kadegedze. Several years ago, we started research into immune reactions in lymphatic nodes and in tumors. Before that, for many years, the processes in tumors were investigated according to the peripheral blood reactions. What I would like to talk today is this diagram where we can see how the tumor immune editing concept has been accepted by researchers globally, and how it was investigated further on in other research and publications. There are several stages: the elimination, the equilibrium, and escape from immunosurveillance. Normally, what we are presented is some specific material. We look at the peripheral blood, because quite often we are not presented with tumor tissue or tumor node. But usually we are presented with patients with a well-developed tumor. So escape stage is, again, the stage when we have the specimen of tumor in our laboratory. Pro-tumor and anti-tumor immune response and immune cells play a crucial role in this respect. So in the right part of the slide, you can see the process of the anti-tumor immune response and the activation of lymphocytes, cytotoxic lymphocytes and their activation, and also the components that correspond to the pro-tumor phenotype, as well as various factors of the host body influence the layout of tumor cells. So cells can both demonstrate pro-tumor and anti-tumor functions once at a time. All this research is not done in vain. Over many years, this was of little practical value, but on this slide you can see the background, the historical background of immunotherapy development and emergence. So look at year 2016. The immunotherapeutic modalities are being actively implemented in practice. This means that finally we are able to treat cancer by manipulating the immune system. As for tumor-infiltrating lymphocytes, and this is what I'm going to talk about today, on this diagram, you can see the number of research and the number of publications per year devoted to this topic. If you look at the diagram, you can see a surge in research over the last 6 years. A second surge, actually, that follows the first one in 1999, to be followed by a decrease because all the results obtained were merely theoretical concepts. Clinical medics could not identify how all these therapies could be implemented, but there was a surge over the last 5 to 6 years when indeed we were able to identify the prognostic and predictive value of the research to develop a target immunotherapy. In patients with different nosologic cancer, such as melanoma, head and neck cancer, breast cancer, bladder cancer, ovarian cancer, esophageal cancer, colorectal cancer, renal cell carcinoma, prostatic adenocarcinoma, and lung carcinoma. So in such patients, the association of T-cell infiltration is associated with positive forecasts. Our laboratory encompasses huge databases across different nosological forms of cancer that cover hundreds of thousands of patients. And actually, over 35 years of research, we were unable to notice any dependence of the TIL cells from the nosological form of a cancer. So therefore, we can speak about some disruption in the structure of immunocompetent cells that is not dependent from the nosological form of cancer. This slide is devoted to breast cancer treatment, where tumor-infiltrating lymphocytes are interpreted as a predictive factor for therapeutic efficacy. So this research was carried out by many authors, approximately 40 researchers, and this publication was named the best in 2015. Well, again, this is not our data, but this data evidence that TIL have a positive role in patients with breast cancer. And this is something that you will see in many publications. Usually, this research is done on immunohistologic specimen because it is easy to look at a specific marker at a specific time. Here we can see the role of infiltration in intratumor cells and their relation to tumor nodes. This is, again, breast cancer. As early as 1990, when we had flow cytometry and a lot of monoclonal antibodies, then we started to perform research with flow cytometry. In 1993, in Russia, the first results were published in Vestnik Research Journal. Of course, in our laboratory, we also look at peripheral blood count in primary cancer patients and in patients with who receive immunotherapy, in particular in patients with melanoma. Today, we have studied approximately 150 specimens. So how do we do that? What's the procedure? First, we take the specimen, then we process it, filtrate the tissue so as to have a suspension as a result. So this suspension is put through morphological control by liquid-based cytometry. Of course, we compare our results, and it is not always the case when we come up with the same results. This is how we look at specimen by flow cytometry and liquid-based cytometry. Flow cytometry allows us to evaluate T lymphocytes in terms of their binding capacity. As you know, we usually can accumulate multiple events so as to assess the phenotype and the structure of cells, because not only infiltration is important, but also the phenotype of cells that are responsible for immune response. Another case is breast cancer, and in this case our data was not different from other global data. Ovarian cancer, with very extensive infiltration, 35% almost. Oral mucous cancer, absence of pre-morphological research, and again a different scenario. Flow cytometry and liquid-based cytometry gave us similar results. Melanoma, absence of infiltration, many events accumulated, and 2% cell population, CD45 positive cells. And again, lymphocytes identified in tissue in melanoma. Well, again, as I said, the degree of infiltration, of tumor infiltration, is an important factor to predict the response to immunotherapy. Today, we go on accumulating data, but we performed the preliminary statistical processing. So we looked at 62 specimens of tumor in primary cancer patients fit for surgery. And we looked at the frequency of various scenarios in terms of infiltration. 35% of specimens demonstrated less than 1% of TIL lymphocytes. In half of cases, and in 13 patients, this value was over 10. This is our marker panel. It must be universal. Sometimes we obtain this specimen during surgery, but in case of melanoma, we usually perform core biopsy to obtain the specimen. So these fragments of tissue are usually evaluated histologically in terms of pathomorphosis and so many other research. So our task was to look at the structure of immunocompetent cells. And therefore, we came up with this panel that allows us to look at T cell population, NK cells, regulatory T cells, and also syntactic potential, and the number of effector cells. This is what it looks like. T cells, 3-8 population, and very rarely we are presented with double positive 3-8 cells. Again, T cells and low count of B lymphocytes. HLA-DR 19, HLA-DR 19. Almost This is the most successful specimen. Very low count of NK lymphocytes and NKT lymphocytes in tissue. Regulatory CD4 lymphocytes. There is a certain number of them that are activated, and then we looked at the co-expression of CD25 and 127 on the membrane, and activation of lymphocytes with co-expression of CD28B, and so many other populations. And effector cells are almost absent, CD16, whereas CD8 are well presented in lymphoid tumor elements. And this is the accumulated data in T lymphocytes, almost 95%, 1-to-1 ratio. Non-specific effector CD8 cells are almost absent, which makes it different from what we had in peripheral blood. Low NK lymphocytes, but NKT is higher, B lymphocytes low, no activated T cells, but CD4 lymphocytes are present, activated. Here, this is the activity of CD8 and CD16. Regulatory cells, CD4, because the specimen is quite complicated, it's complicated to process, therefore we decided not to go into any extra research of FOXP3. So we just decided to marker 127, the surface marker, CD8 lymphocytes over 50%. This data is highly innovative and is our breakthrough because such research is only possible with flow cytometry. Our task is to evaluate the co-expression of a marker combination on the cell surface so as to be able to evaluate the function of these cells. Well, any theory sooner or later is bound to have some practical implementation. So today our research is closely related to breast cancer. And these data was recommended to develop therapeutic modalities for breast cancer. Depending on whether the T lymphocyte that infiltrate the cancer is high or low, so the analysis of the phenotype must be looked at through the FOX analysis, which is flow cytometry, in fact, so as to understand the functional load of specific cells. So these are the outcomes. Our approach allowed us to look at and identify in 100% of patients the TIL cells. Whatever the localization, the phenotype is almost the same. In CD45 lymphocytes, T cells are predominant. When looking at lymphoid cells, TB and K, so those must be 100%, plus minus 5%. If the T cells are 90%, then B cells and NK cells are 5 to 10%. And this is what we had actually. I could not rewind it. Well, I can't do it back. Oh, it's a pity I cannot rewind it back, because I would like to say, to mention the names of our team, of those who are involved in this meticulous work. We work in online mode, which is kind of a buzzword today because usually surgeries are done both in the morning and in the evening, and we take the specimen and work with so-called a fresh specimen, so to say. So now I would like to say a couple of words about regulatory T lymphocytes. CD8 are predominant, and whatever the nosological form, the immune response in patients with solid tumors have predominant regulatory immune response mechanisms due to CD lymphocytes. This is our team, our senior researchers, minor researchers, and fellow researchers. We also cooperate with other laboratories in other research centers, with surgeons, with clinical cytology laboratory. And also, as a default, we usually obtain informed consent from our patients, and quite often they agree for core biopsy, even for several procedures of core biopsy, for the sake of research. Thank you very much for your attention, and I also would like to mention that we have been intensively looking at the structure of immunocompetent cells in peripheral blood. Today, we combine this research with looking at the events of how tumor cells and immune cells interact in tissue. Every cell has a time to live and a time to die. These are the words by John Campbell. I read his book when I was working on my thesis. Anatoliy Baryshnikov and Madam Kaderidze were my scientific consultants, and Mr. Baryshnikov was my supervisor for my candidate thesis. So I was happy to have such tutors, such teachers. And every time I came up with some new project, I always addressed them for advice, for consultancy. And today we miss him a lot in our life and in our work. Thank you very much for your attention. One question, please. We can take one question. Thank you very much for the report. It was highly exciting, highly practical, and crucial. What's the role of positive T cells? What does the literature, does research say? CD4 plus and CD8 plus. You said that there is a certain percentage. Well, I just said that we had such a clinical case. But what does research say? Well, these are activated cells. They should not be there as a norm. Well, we do not have extended databases for this population. Usually, what we see is just brief commentaries. when researchers looked at peripheral blood. In tissue, these cells have never been researched or evaluated. There is usually a task to look at regulatory cells, and only regulatory cells with specific phenotypes, without looking at linear markers and the structure of other populations. As for CD95, well, CD95 is presented in several specimens, but then we got rid of it because there are so few specimens for research. Yes, indeed, we look at CD95 expression in peripheral blood in CD8 lymphocytes. This is important to have an understanding of the co-expression of protein, and you know that CD8 can perform different functions, including immunomemory, so we look at blood as well.